It's often been said, sometimes too often, that those who do not learn from the past are doomed to repeat it. And we see evidence of that thinking in programs like Meaningful Use, Patient-Centered Specialty Practice, Patient-Centered Medical Home, and others. Welcome to the eClinicalWorks podcast. I'm Adam Salati. With me today are Dr. Michael Rocklin and Dr. Michael Shapiro, nephrologists at Denver Nephrology, two individuals who've embraced technologies to see where they've been and where they're headed. And we'll be discussing some breakthroughs that they've made using the reporting capabilities available with eClinicalWorks Business Optimizer, or eBO. Doctors, thank you very much for being here today, joining us and giving us your thoughts.
Thanks for having us.
Welcome. What capabilities did Denver Nephrology have to track performance before eBO reports?
Well, I think it's really important to separate out our capability with regards to looking at financial performance from clinical performance. And I'll defer discussion of the financial points to Mike Shapiro. But with regard to clinical performance, even in the late 1990s, we were looking at things such as clinical access, what access was being placed in our patients, but we did it completely manually. So that meant we had to send nurses out, visualize what access, record that on a piece of paper, bring that back, and then collate all that kind of data. So it was really pretty onerous, and the amount of data that we could collect was limited. We then, in the mid-2000s, migrated to our first, what I would call first EHR, but this was sort of purchased without really any forethought with regards to its capabilities for looking at structured data. And in fact, it had really very limited capability. And thus, what we did is formed an open database connection. I was able to convince the company to actually give me a data map of all of their tables. And with those two pieces of information, I was able to actually do some sort of early, sort of rudimentary kind of clinical reporting, looking at quality with regards to anemia and bone and mineral disease. But again, really limited compared to what we can do today with eCW and eBO. And so, essentially, when we were looking to leave that system because we recognized that it was never going to have the capabilities that we were going to need down the road in the long term, we actually put together what we thought was a fairly extensive process. We actually looked at initially about 100 systems, some web-based, some not, in terms of client server, and we had a process where we did a quick survey. And then we limited that down to 10, and finally we invited 3 out to visit us here and show us sort of a deep dive into their product. And part of that process for me going into it was looking really, and really very important part of that process was looking at the reporting capability, because we now had the skill set and recognition that putting data into any system, in order to get the value of that work, you need to be able to get it out. And so I was very impressed with the registry functionality of eCW, but even with that, we recognized there were some limitations. And then when I met Raghav Rao and Ken Rosen and we looked at eBO, we really thought that was an important add-on that really was a major plus for us in our selection process of eCW.
And on the practice management side, we've always been able to do some revenue cycle management reports. We, obviously looking at revenue, where it's coming from, payments by insurer, those sorts of things, number of office encounters, where they were seeing provider productivity. And those reports were mostly canned reports, and there wasn't a whole lot you could do other than dump the data into Excel or other third-party software like Crystal and see what you could make of it. So that's pretty labor-intensive to do that. We've moved into a little bit different realm now, I think, of reporting and reporting capability with eBO.
So having eBO for a few years now, what's the biggest difference, and where have you seen them used to the greatest effect?
Well, again, I think it's sort of two parallel functions in a way, although they're integrated, and that's the business side of it and the clinical side. And one of the things we've been able to do is to crosswalk between those two, figuratively speaking, to be able to provide meaningful data, or at least begin to provide more meaningful data on how we take care of patients and what the financial impact of that might be, the resource requirement impact for providing that care, and those sorts of things. So I just think that the reports are more sophisticated than they were before. The opportunity to use Report Studio and create your own reports outside of the limitations of the Query Studio. Those things have been very helpful for us in data analysis.
Sounds like one of the big differences, the static reports you had before and now very customizable reports that you have available. I'm going to ask each of you this question, so we'll figure out who goes first. Maybe Dr. Shapiro. Give us an example of some report that's had a big impact on what you guys are doing now. What are you focusing on?
Well, most recently, we're looking at the impact of the Affordable Care Act and the individual mandate and the shift in insurance acquisition by patients and its impact on previously write-offs or bad debt, because so much of the care that we provide is uncompensated, particularly at the hospital level. So we've been able to do reports based upon individual insurers, comparing it to the same time period, saying a year ago prior to the advent of the change in insurance. What are we seeing more Medicaid patients? Are we seeing more commercial insured patients? Are we seeing more Medicare patients? What's the impact been? As well as the volume. So what's happened now to the billings associated with that? What's happened to collections? So being able to do those reports has been, I mean, they can be done within minutes, and that's exciting to be able to do.
And are you far enough along yet to see how that's been going, or?
Well, we are, except that we know that the impact of that really didn't take effect until about the second quarter of 2014 in terms of the individual mandate and people acquiring insurance through the exchanges, et cetera.
The sign-up deadline.
Right. So we're beginning to see something. I think it'll be much more meaningful as we get further along in the year.
All right, and Dr. Rocklin.
I think I'll share some reports on where we're going clinically, but really what I've seen happen in the last 2 years is we went from just looking at trying to look at just quality metrics for, say, something like anemia or bone and mineral disease, looking at lab data, to being able to begin to combine and join data in various interesting ways and customize clinical reports to begin to look at not only outcomes, but the idea that we can actually use a structured data model that in our workflow to sort of augment care for our patient population outside of the encounter itself, the physician encounter with the patient.
And you've been able to do that, and you have some examples here.
I do,
right?
I do.
Would you like to share some of those?
Absolutely. So the first example is what we're calling the Denver Nephrology dashboard for bone and mineral disease. And what we were able to do in the first graph there is pull out various providers, which we've customized so we can pick any group of providers. And how this graph shows is the providers in a pod. So we're 30 physicians, and we're stratified into various pods around town. And so for us, it kind of makes sense regionally to look at our practice. And so what on the bottom there on the x-axis, you have 4 physicians in my pod, and my initials being MAR. Being the last physician there on the graph. And what the first graph shows is sort of the intact parathyroid hormone level, which is something we look at in patients with chronic kidney disease, and certainly we want to keep that in a desired target range. And so this now allows us at a very high level to look across our practice at how we're doing with that, and it's stratified by stage of kidney disease. We were able to accomplish that as well. And what you see on the graph is as patients progress in their kidney disease, their parathyroid hormone level does rise. And what's also on this graph, though, that we were able to add is looking at there's baseline values for the entire practice. So somebody like myself and Dr. Shapiro can look across our practice and immediately see if there are areas where we need to focus efforts. And providers can see how they're doing relative to each other, which helps, I think, motivate individuals. All of us as physicians come to work, I think, every day, doing our best. But there's so many stresses on a visit. The patient comes in, has their new issues. We're trying to look at anemia, bone and mineral disease, acid base, blood pressure, volume status, that sometimes things like this get inadvertently less attention, let's say. And if you can figure out a way, which I think we're really on the verge of doing, to manage a population by looking at various values like this, I think you can really improve the quality of the care.
Well, you've got some very complex information there, and you've even incorporated benchmarking across your organization, which is a very advanced thing. I mean, in the past, a lot of practices would have to rely on an insurance company to try to do that for them and work off the claims data. But you've done that with your own clinical information that you capture in eClinicalWorks with these reports?
You know, since you mentioned that, one of the things that I think happened and really pushed us forward, I think in the last couple of years, was already we're starting to see a change in sort of the environment where payers are coming to us with their data, which is often payer-based, based on billing and whatnot. And in one case, a payer did come to us with some data about some outcomes having to relating to access. And actually, we found in looking at our own data and being able to sort of look at our own database and our structured model that we put together, that their data, while it could be interpreted as accurate, really didn't give the real clinical picture of what was going on. And they were very receptive to that. And I think that was an extremely important thing we were able to do this year. And we continue to share our data with them. And I think that's driving forward improvements in their understanding of where the holes are. So as an example of a clinical challenge that we faced with patients as they progress in their kidney disease, we really want to be making sure that they get the appropriate access, education, and transplant education that they need, so that transition is smooth and that we don't have patients crashing onto dialysis and having to have plastic catheters in their chest, or that they don't get the evaluation to make sure they get possibly even a preemptive transplant.
The problem was either they weren't getting the education or we didn't know they were getting the education.
They're getting it, but we wanted to find a structured way to make sure that those gaps were filled. And so this report, which can be emailed monthly to our providers or to their nursing team, shows how, in the left-hand graph, shows their laboratory data over whatever time period I select, and it shows, and it's specific for patients with low GFR, meaning low kidney function, okay? And it shows the provider in a quick glance, how is that kidney function changing over time? And certainly if it's falling, that should grab your attention. And then on the right side pane, shows them their clinical status at each encounter in that time frame, and it allows the provider to quickly look outside of the visit, is the fistula in place? Have they gotten the appropriate education? Make sure they choose the modality of their choice. Where is their transplant? Are they listed, or are they on hold for some reason? If they're on hold, it allows you to jump in there and make an intervention.
So again, that in terms of integrating on the business side of things, because we are businesses, practices, we have to function that way. We have to be able to bring in revenue and manage our expenses, and for that reason, we want to become or maintain and continue to be the nephrologists of choice in our community. So we have to be able to bring this data to the payers, in this particular case, private commercial payers, and say, this is why you should use us for this. Or if they do come to us and say, this is what we're seeing, we don't like it, or we do like it, we say, well, actually, let us show you the actual data associated with that. And as we get more sophisticated with putting this package together of what we call metrics or measures that matter, that's something I think that will provide value, right? We're all talking about value in the shift from fee for encounter to fee for value. We're talking about shared savings programs, accountable care organizations. They're going to want to have physician practices that buy into this and that actually have done something about it. So we're excited about that opportunity.
More tools in your toolkit. In other words, creating a two-way conversation with the insurance company as opposed to something that they're dictating.
Right.
Absolutely.
And showing them, taking the lead and showing them that, hey, you know what, this is what everybody should be engaged in and should be providing for you and for the patients, because ultimately the goal is improved quality of life for the
And you've been
patients.
able to do that with eBO.
Absolutely.
Because of eBO.
Absolutely.
Great. So your reports seem to have tremendous impact, or potential for a tremendous impact anyway, on your operations, your outcomes for your patients. Of course, only time will tell, but it seems like we've got some good evidence so far. Who's writing these reports?
Well, primarily in terms of authoring in Report Studio, the clinical side of things, I'm doing most of that. But in our organization, I think, in terms of writing reports in Query Studio, Dr. Shapiro, our COO, Beth Irwin, and also our billing manager.
Right.
I think all four of us, four of us use eBO.
And some on the Report Studio side, but I tend to use mostly the Query Studio. I know you use Report Studio extensively.
Yeah.
And you two are doctors by training,
Yeah.
obviously. No, well, maybe some previous experience with it, but you've been able to dive right in, create these reports very, very tailored to your organization and the outcomes that you're looking for.
Yeah, do you want me to share a couple more?
Yeah, please do.
Of these reports that we did. So another report that I think has been really important for Denver Nephrology was trying to make sure, again, relating to getting access into getting patients educated as they transition if they have progressive chronic kidney disease. And so we devoted a lot of attention towards the idea of workflow. And I think as I mentioned, there's a lot of stressors on visit, on an individual visit. In addition to just that, you now add into meaningful use and PQRS. And certainly we're not here today to debate the merits of those two programs, but that adds a lot of pressure on physicians when they're in the room. So it's very critical for anyone when they want to start to devise or look at structured data outcomes to sort of help them in not only looking at quality, but helping to augment their care, to think about the workflow of how that's going to be added into the actual visit encounter in order to get buy-in by your provider population. And so I think that's something that we've been really successful with in the last year. And it absolutely needs to be said that we weren't successful on a couple efforts with this. And this is not our first try at it. And I think that what the data is in the next graphic, really we're able to pull out, for instance, the percentage of patients with a GFR under 25 and what is their access status. And so that's really important to us because we want people to start with fistulas when they end up on dialysis or have their peritoneal dialysis access in place so that they don't crash in the hospital. Okay, that's important to payers as well because it costs more money. It's better for patients, so it's better for everyone. So one of the things we did is we have a graphic analysis at a high level. Again, we can look at whatever providers we want and give them monthly reports on how they're doing with regards to the access development or progression of that access. So if someone, for instance, has been referred for what we call vein mapping to look at their veins to see where an access could be constructed, and that sits in that status month after month, that's a problem. And sometimes there might be 3 to 4 months between encounters. In the old I shouldn't say old, but the prior way we did things, you had an encounter and you had another encounter, you might not see anything about that chart in between. What we can do now is monthly have emailed reports, and a provider can see based on the last encounter date quickly that someone's stuck in a status. Maybe they got sick and canceled their appointment and they missed it for their access construction, and now they're just lingering. We now can fill that gap, and I think that improves care for that patient using this kind of a report.
Removing the risk of out of sight, out of mind.
Absolutely.
And putting it more in front
and they're
of you.
not anymore, because we also have, in this report, we have outliers. So we identify those outliers and we fill that gap using our nursing team to help the physician providers.
So historically, right, any business, and again, I don't want to make it seem that we're focused just on business but medical practices require you to be solvent. And so businesses can usually differentiate themselves and compete based upon quality, service, or price. Well, our prices are more or less fixed, right? Especially in nephrology, it's mostly considerably government pay, and those fee schedules are fixed. Quality is something that, well, everybody is great. They're board certified nephrologists. How could you differentiate one from the other? And so we would always focus on service as the clinical competitive differentiator. We're still trying to do that, so that's still part of our core strategy. But now we're saying, you know what, there is an opportunity to differentiate based upon quality, based upon value. So how do we be able to, how can we do that? So we've made the decision as an organization to invest in that and to create, Michael is our chief medical officer, to create a position like that. I don't know any other private practices that have CMOs within their practice. I mean, unless they're large medical groups. So this is something that we think is really, really important, and developing more of this and applying it so that we can show what we're doing, make ourselves better as well as part of a continuous quality improvement process, and then provide that added value to, right, the triple aim, right? We have better care for populations, right, and savings to the taxpayer and to everybody else.
We're going to continue our conversation when we come back, but right now we're going to take a break. More from the eClinicalWorks podcast coming up.
eClinicalWorks offers a variety of services for you to take advantage of eBO in your practice as part of its professional services umbrella. If you are a practice looking to get started with eBO, make sure to take advantage of the free eBO webinars on navigation, practice management, and Query Studio offering. Once complete, look up the eBO class schedule in Westboro and regional offices to take your reporting skills to the next level. If you are a practice that is looking for a one-time engagement with a report expert, consider engaging with a member of the analytics team to solve your unique pain point. If you are a practice that is looking for a comprehensive engagement with a reporting consultant assigned to your account that includes discovery, report authoring, on-site training, talk to your account manager about full suite analytics services. Help eClinicalWorks unlock the value of the data stored in your eClinicalWorks database by using eBO to its full potential. Reach out to your account manager or visit my.eClinicalWorks.com for more information.
Welcome back to the eClinicalWorks podcast. My name is Adam Salati, and I'm joined today with Dr. Michael Rocklin and Dr. Michael Shapiro of Denver Nephrology. We're talking about how eBO has been able to give them some more insight and help them change their practice. So over 400 reports come preloaded in eBO. Why did you feel the need to create more?
I think that those reports are absolutely an amazing asset to any practice that those are provided basically with the program when you take that on. We have, I think what practices find is that you have specific questions that for instance, as an example, you could take the canned eBO report that will look at encounters and give you the zip code that the patient came from. And that's terrific. And at one level, maybe you want to look at that. But we had, as an example, a specific question about a year and a half ago whether we should enlarge our practice and go to another metro hospital and go to and establish an office there. In the past, certainly we would do some analysis, try to financially, figure that out.
What was that like?
But it was more like we sat in a room. It was kind of how we did zip codes, but it was how you felt.
What are the other What are the other specialists thinking about doing? What's going to happen with primary care in the area? And it was sort of that general feeling of, we probably need to be part of that, or we don't.
And honestly, this is a good example of where I actually did work with Raghav Rao.
Of HBI services.
Yeah, the HBI services. It was sort of part of my learning process, and we had a specific problem which I sort of laid out for you, and we were able to actually create a report that pulled all the encounters we did, not only in offices but in the hospitals in that southern part of town, and then represent that in a graphical analysis, pie charts of what percentage of patients came from various zip codes. And then we grouped them by city, and we were able then to show really good data that, for instance, 25% of our encounters at one hospital were likely to migrate to this other new hospital. And that's important information and hard numbers based on what we were already doing, and really, I think, facilitated that decision making on where we needed to go. And the interesting thing is I actually have the pie chart we're going to show you here is a newer version of that. And what we found is actually it was pretty good. The percentage of patients at the one hospital did decrease by about 50% when the new hospital opened, and now our encounters where we're going to the new hospital are up there.
And you were able to anticipate that based on your report.
Absolutely. So I think that was a business application of our customized reports.
There's different ways to create your own reports in eBO. So which do you use, Query Studio or Report Studio?
I use Query Studio. I've not learned all the details about how to write my own reports. And then if it goes beyond what I need at that moment, I usually will tap the skill sets of our manager of billing, Lori, who understands how to write reports as well.
How have you built some of those reports in Query Studio? What's the process?
Basically, think about first, I think anytime you do a report, you have to think about what data you would like to actually analyze, right? Yeah. What problem am I trying to evaluate and to get a report on? And sometimes it could be simple, and I'll drag various data blocks into it, and they'll say, no, you can't cross-join those. Nuts, okay. I'll try something a little bit different with this. And then just say, okay, I want to see patient encounters by provider, at location or something like that. And then I'll look and see how the report shows up and say, hey, that's pretty good. That's the information I want. Or if not, I'll begin to modify that a little bit more, remove something, add something. Let's look at a certain date range. Let's look at certain CPT codes. Let's look at certain ICD-9s, certain 10s. And then if it's more sophisticated than that, that's when I turn for help.
Using that drag and drop functionality to just very quickly create a report
Yep.
to give you what you need to see.
Save it in my own folder, essentially, so I know, and I can label it, click on it every time I want to look at it repeatedly, or send it to myself. I haven't usually actually done that. I've gone in every quarter. I look at things routinely every quarter, frequently more monthly. But I'll go in and say, okay, it's my time to look at these. I'm going to use the report I already wrote, just like I think we're doing with this.
Yes, I think Query Studio is a fantastic tool. You can drag and drop things very easily. It really takes not a lot to start creating your own reports, and you can get great data out of that tool. The problem is there's limitations, which Dr. Shapiro has already mentioned, regarding you have to stay in one subspace. And I think that when you want to start to do more interesting things with your data, such as looking at different parts, different subspaces, structured data with different queries, where you want to join those with different date ranges that you want to parameterize and pass in to your reports, you got to really move on to Report Studio. You can't stay in Query Studio.
I can see in my mind's eye maybe some watchers glazing over when we're talking about joins and
Sorry.
datas and subsets. No, it's not a problem. It's because my next question is, whether it's the drag and drop functionality of Query Studio or the much more powerful and customizable functionality you get in Report Studio, how did you guys learn to use these services, or the tools, I should say?
I think that, I mentioned earlier our experience with Crystal reports and becoming sort of familiar with database and then SQL a little bit. But I think it needs to be stated, I am absolutely a physician. I have no computer science background whatsoever. And I think that providers, if you have the motivation and interest, can get the support from eCW and the Healthcare Business Intelligence Group to really learn how to use these tools. Things that helped me initially were when Raghav Rao, again of that group, came out and met with us for a couple days as a larger group, and then I actually spent 2 days just with him one-on-one, where I identified some problems and we created some reports. And then from there, there's a book by, I'll give Dan Volatich a shout out. I read that, I obtained that book and at Raghav's recommendation, and have looked through that. And then there's resources on the internet, and then ongoing support, though I think it needs to be mentioned that Raghav didn't just disappear. As I sort of expressed interest and began to learn and create my own reports, we hit walls, absolutely. And when you're in isolation in a group, as opposed to the larger sort of eBO group where they can bounce things off each other, you can hit challenges. And so Raghav has been great about sort of getting us past those barriers when we hit those.
We're talking about eClinicalWorks HBI services, of course, and they offer training, support, assistance with report creation. If you're a smaller practice and you don't have internal resources to maybe focus on that type of thing, was there ever a deliberation that you guys had to go through whether going to HBI services would pay off in the end?
Well, I think what we were convinced once we got the introductory session on using Query Studio that there was a lot of power in the data. And so once I think we reached that point of saying, we need to be able to do more, then seeking out additional services. I think we felt from the very beginning that it was important to spend a little bit of money to learn that. Now the question is how do we take it to the next level, and what resources do we need to add to our business to be able to help our chief medical officer essentially focus on the medical aspects of things and say, I need this report, much like I do on the revenue cycle management side, where I can say to Lori, can you run a report for me that shows this? And then when she brings it back to me, I say, no, what I'd really like to look at, I know I'm changing it a little bit, is the following. And we can work together on that without me having to do that labor part of it. But I can think about what I'd like to see, get input from the rest of my partners, our executive committee and such. This would be meaningful information. So we're at that phase now. Think of getting ready to evaluate what do we need and what can we bring on board.
No would have been acceptable as well, but I'm just, just kidding. We're going to come right back after this break from the eClinicalWorks podcast. Be sure to join us at the 2014 eClinicalWorks National Users Conference at the Orlando World Center Marriott in Orlando, Florida, October 17th through 20th. We encourage you to book your reservation early and to bring the family with you to this remarkable family destination. Please visit our registration website at specialevents.eclinicalworks.com to book your hotel and register for our 2014 National Users Conference. Welcome back to the eClinicalWorks podcast. We're wrapping up our interview with Dr. Michael Shapiro and Dr. Michael Rocklin. With all the work you've done with your reports, would it have been more useful to you or more valuable to you to have hired a consultant to come and do some of these things for you?
You know, that was definitely something not only that was considered at Denver Nephrology, but we, in contrast to using like HBI services, we actually did hire a outside consultant who claimed to have expertise in database interrogation and analytics. And unfortunately, our experience was really not good at all. That individual actually really didn't, in the end, after 6 months, provide us with anything. And I think our experience with that was just that we, as a business medical organization, really didn't have the skill set internally at that time to evaluate this individual. And so, you know, people can say a lot, but they really, they have to be able to produce. And so I think that's something that I would just caution people, if you decide to use someone outside of eCW business, to be very careful.
So in order to get useful information out of the reports, obviously we have to get it in there in a way that we can look at later. How do you capture the data you use in your reports?
So I think one of the most important things that came out of the process that we've gone through the last 2 years was a strong understanding of the eCW product, the EMR itself, and the flexibility that we found, especially in the HPI section with the different categories you could create. What we figured out is that we could create a new category, which we call the CKD, chronic kidney disease module. And within that module, we include then structured fields for education, which obviously we're trying to track, you know, the learning process for the patients as they learn about transitioning to various kinds of therapies, if they're going to go on dialysis or be transplanted. And then we have a separate structured area for access, which we've kind of touched on today. And then we have a separate structured area for transplant, and finally one for research, where we can identify patients as potentially wanting to, if there was something available to them, and they might want to hear about a certain study within our research division. So those 4 areas we felt were critically important for our patient population and things we wanted to track. And I think the design of that was critical to get physician buy-in, because you don't want 4 more boxes during a visit when you've already got the stresses from meaningful use in PQRS and everything else going on. That's going to distract physicians. They're not going to use it, and what you get out is only as good as what you put in. So what we found is that by structuring this in a way that it worked within our workflow, which physicians understand because we're doing the workflow, we got universal buy-in by all 30 providers because they saw value in it. One, it structured what they were already doing in another part of their notes or in various parts of their note, and sometimes to various degrees. Suddenly it structured all that in a way that it made it easy for them on every patient to know what status. And then where they really got buy-in is suddenly they get these reports that we've been showing monthly or quarterly, showing where their patients are, and they can see the value when suddenly those gaps get filled in their patient's care. And so I think that kind of flexibility within eCW really led to our ability to develop that workflow and understanding that. And another really beautiful thing for us is that since our patients do transition from office to dialysis or to transplant, that category, or we'll call it the CKD module for us, could move from template to various areas and back. They go get transplanted, they come back to our office. That then, in other words, we have that data, it flows with the patient between different offices and different sort of status.
So your primary business is healthcare. You're both doctors. You both work at a nephrology organization, but yet you've devoted a lot of time and thought to creating these reports and fine-tuning these workflows associated with the reports. So how does this fit in with the overall strategy at your organization?
Well, again, we talked a little bit before about the strategy being of multiple components. How we differentiate ourselves and become providers of choice for the various stakeholders that we want to have, as the payers in particular in this, and our patients, referring physicians. So service is obviously really, really important, but providing good outcomes and value for the patients and then for the community, and ultimately for the payers and organizations that start taking on risk or shared savings, that's going to be really, really important. It's evolving now, it's emerging now, and so being able to structure it in a way that patients get added value, because we have to do that first. If you can accomplish that and then accomplish the other aspects of it as well, by saying, hey, this is what we can provide, if you would like to use that, then go ahead and do it. Our patients like it because of the following. We think we're delivering better patient care. We'll show you that we're delivering better patient care. Look at this, for example, and we'll show them a report that maybe shows something about patient improvement, clinical improvement, or stability that heretofore hasn't been shown. And if you can do that, that gets the attention, of course, not only of the patients, but of the referring physicians and the payers.
I think that's definitely such a high level answer, and it's exactly right on. For me, what has really just driven me the last decade working with Mike has been first quality. That's why I wanted to learn how to do this and be able to demonstrate that, because every day we come to work and we think we're doing the best and we try to do our best, but to be able to actually look at that and see where the gaps are and improve that, I think is so key. And the second driver, which emerged out of that, at least for me, and I've said it a couple times, is that I see that we have so many patients with, there are 23 million patients with kidney disease, and there's only so much, we can see patients only so often, and being able to find ways to manage the gaps using structured data and your nursing team, or maybe it's MAs, is so important. And I think going forward, that's going to be a more comprehensive model of care for patients. That's what drives me.
And we're being asked to do, the whole medical profession, asked to do more with less, or more for less. So we're trying to find out a way to be able to leverage our capabilities and the best way to be able to do that so that we can remain efficient and productive. So we need to use other level providers to be able to do that, MAs, RNs, advanced practitioners. And how do we best do that? Well, right now we get paid fee for service. And we realize that while that's not going to completely change, some of that is being eroded, if you will, into a fee for value. And so right now we see it as an incentive program or multiple incentive programs that are morphing into penalty programs for not providing evidence of showing that value or participating. Meaningful use, PQRS, and now soon the value-based payment modifier. Soon this year for practices of 10 or more eligible professionals like ours. We're stuck in this fee-for-service paradigm versus what Ian Morrison, the futurist, has called the second curve, where we're going to be faced soon with payment for and having to change our systems to support a payment for value as opposed to a payment per encounter. We're stuck in the middle of that. We don't know how long of a timeline that will require. So we're having to put resources in, which is scary for medical practices. How do you hire more people when it's going to actually erode your bottom line potentially, unless you can show value on the revenue side for doing that, added value on the revenue side? It's a risk that we've been taking for a few years, and we're sort of doubling down now to try to enhance that, and we think we're going to be successful.
It's almost as though we're being asked to implement a lean production cycle, somewhat like you've heard of from Toyota for so long.
Sure.
And you need that vision to propel you forward, or to let you navigate your way through it.
And it wouldn't hurt if we get some of those payers to say, you know what, we think what you're doing is right, and we're beginning to see some traction with that. and to say, you know what, we like what you do. Can you do more of it for us?
Thank you guys both so much. One question for you before we go. Are you headed to the eClinicalWorks Users Conference this year?
Absolutely.
You'll be going? All right, wonderful. Well, we'll be happy to see you there, and we hope to see everybody there. For the eClinicalWorks podcast, I'm Adam Salati. Thanks for joining us.
Welcome back to the eClinicalWorks podcast. I'm your host, Greg Casado. First off, I want to say thank you to Dr. Rocklin and Dr. Shapiro from Denver Nephrology for their great insight and their daily use of eBO. Today, we're joined with Raghav and Sagar from our eBO team, and they're going to answer some user-submitted questions. Thanks a lot, guys, for joining us. Everybody doing good today?
Thanks, Greg. Thank you.
Awesome. So, first off, we have a question from Peter in Nashville, and he said that he hears that there's a new version of eBO coming out, and he wants to know a little bit more about that. So what can you tell us about some of the future developments with eBO?
So, Greg, the new version of eBO is going to be called eBO 7, and this is going to be one of the biggest eBO releases so far. We are not only releasing a brand new metadata package and set of reports, we are actually updating the whole reports engine. What that means is better performance. We've highly reduced the content to make it easier. So we've actually, rather than having 20 reports that kind of do similar stuff, we've created one super report that does everything that those 20 reports did.
One super report.
Yes, yes. And another thing we did was we created an interface with the practice's accounting system so that they will be able to export the data directly into their GL systems, QuickBooks integration, the works. And we have a couple of more enhancements, for enterprise directory customers, a lot of good stuff, and really, really excited about it.
Fantastic. That's some excellent, the idea of one large super report is just, that's going to help out so many clients out there, just like that one-stop shopping concept, which it seems to be what you guys are working towards.
Yep.
Excellent. Well, we have a question from Lisa in Dallas, Texas. She'd like to know, what are some of the best practices in getting up and running with eBO?
So I'll take that. So essentially what we offer as a suite of services, both free and as well as under our professional services umbrella, is we offer free webinars. There's 5 free webinars that run at any given time that you can go to my.eclinicalworks.com and sign up for. In addition to the services that are free, we also have a ton of guidebooks, documentation that you can take advantage of. And then if you have needs that are one-time, ad hoc, you can always reach out to your account manager and bring that up with a member of the analytics team. And we'll be more than happy to serve that one-time engagement.
Okay.
If you're a larger customer and you want dedicated time with a reporting expert, then what we do is, as a part of our on-site services, we have consultants that we go out to customers, understand your needs, build out an implementation plan for you, and help you really get successful in using eBO.
Excellent. So, unfortunately, we didn't have a lot of questions today when it pertained to eBO, but one thing I do want to ask both of you guys, and kind of lean on your expertise with eBO, is what are some general recommendations you would make to our eBO users, our eBO clients?
So, some of the things like Raghav already mentioned, the free webinars, make use of it. It's free, it's right there. If the timings don't work for you, we've recorded webinars which you can use. Okay, obviously, you can't ask questions on those, but you can always email somebody and get those answered. We have in-depth documentation on how to run reports. Most of the information that clients usually need is already available in form of a canned report. It's just that it's sometimes hard to find, which we are going to solve with eBO 7 with the super report format, Another thing to take care of is knowing what they get out of the reports. So understanding just how they run the report, they can always go through the guide and see the logic behind the report. We have actually explained each report in a lot of detail. So a lot of free resources available on my.eclinicalworks, which they can use.
Excellent. Raghav, do you have anything to add?
Sure. One of the things that we do a lot in implementation is we don't take a one-size-fits-all approach. So coming in to any implementation, we understand the needs of customers. And so what that really helps us achieve is some outcomes that are very specific and targeted to a customer's unique situation or customer's unique need. And from a best practices standpoint, really that engagement with your consultant and that time that you spent in telling us your pain points will really help us help you better.
Okay, excellent. Well, both great responses. So, well, that's all we have time for today with our podcast on eBO. So first off, I want to thank both Raghav and Sagar for joining us in our eBO podcast. And once again, I want to thank Dr. Rocklin and Dr. Shapiro from Denver Nephrology in sharing their insights on how they use eBO on a day-by-day basis. Once again, please take a look at our podcast website. It's off of our regular eClinicalWorks website. You can also find our YouTube page. And if there's any questions or comments you want to make, please reach out to us at podcast@eClinicalWorks.com. Once again, I'm your host, Greg Casado. Thank you very much, and have a great day.
This broadcast and its contents are the sole property of eClinicalWorks and are protected by federal law and international treaties. You are strictly prohibited from making a copy of, modification of, or form of rebroadcasting or re-encoding this broadcast without prior written permission from eClinicalWorks Public Relations, except as may be permitted by law. This broadcast is provided for informational purposes only. It is intended as a personal, non-commercial use. Product specifications are subject to change without notice. Please contact eClinicalWorks Public Relations with any questions. eClinicalWorks V10 EHR is ONC HIT 2014 edition certified as a complete EHR. eClinicalWorks V10 CC 2014 955447-1.